let's talk about why do we need to insert a plastic tube in pleural cavity. You know that in our pleural cavity there is a negative pressure compared to atmospheric pressure. It is about 4 mmHg less than atmospheric pressure, and when we inspire, due to inspiratory signal from the medulla oblongata, diaphragm contracts little and that pleural cavity expands and the pressure still decreases to -6 mmHg, and that helps in sucking in air, and air fills the tracheobronchial tree and stretches the walls of those alveoli, tracheobronchial tree, and a stretch receptor gets activated, and then its signal goes to the respiratory center that alveoli, bronchioles are stretched. Then the inspiratory signal stops and all the alveoli, due to elastic recoils. So it was initially inflated and all those recoils, and due to recoil, all the air that is in the lung, or majority of the air, that is expelled out with expiration. So expiration is a passive process that is aided by the elastic recoil of those alveoli. It does not require use of muscles, unlike inspiration where you require contraction of the diaphragm, external intercostal muscles. So I was talking, why do you need to insert tube in pleural cavity? So let's assume this is the pleural cavity and here is the tracheobronchial tree and these are alveoli. So I have exaggerated the volume of the pleural cavity for understanding purpose. So this is the pleural cavity. Actually these visceral pleura and parietal pleura are opposed to each other. There is about only 5 to 10 ml pleural fluid normally in this cavity to prevent the friction or the rub between parietal and visceral pleura. Only 5 ml fluid. So you can imagine how closely opposed these pleura are to each other. But let's suppose if there is any infection of these alveoli, tracheobronchial tree, and due to that any fluid accumulates here. So this will compress this alveoli and it will prevent gas exchange, that we call compression atelectasis. So if this fluid is hampering the gas exchange, then we need to drain it out. So we can drain it via two ways. One is doing simple needle puncture, like inserting 50 ml syringe and taking out all those fluid, or another we can insert plastic tube. So plastic tube, there are two types. One is pigtail and another is chest tube. So you might have seen the pigtail catheter widely used in surgery. In after abdominal operations, they put pigtail for drainage purpose. So this has less diameter. This has about 14 French diameter. Chest tube has more diameter, greater than 60 French. And the difference between pigtail and chest tube is that this pigtail is soft, flexible, and even with little incision you can insert it. But chest tube is hard pipe and you have to give big incision, so pain is more, discomfort is more, and even the wound that is created with the incision will take a long time to heal in chest tube, and in the pigtail it will heal fast. So there are certain indications where you need to insert pigtail and where you need to insert chest tube. I will talk later. But basically, if the fluid is thin, then, or if in the side the pleural cavity is air, we need to drain air or thin pleural fluid, then we can use this low diameter pigtail as well. But if there is pus, empyema, that you think that it can get clogged up in this small bore pigtail, then we can insert chest tube. So one is the fluid that is accumulated inside this pleural cavity. Another is air can accumulate here. So how does air accumulate? So if there is any blunt trauma or penetrating trauma to the chest, or there is rib fracture, then it breach this parietal pleura and air can leak inside it. So while inspiration, air goes inside it due to negative suction, and while expiration, what happens that this pleura oppose each other and expiration cannot occur, or even if it occurs, it little occurs. So comparatively more air comes in and little air leaks out, so air trapping occurs here. Or air can leak from this side through the, there is alveoli here, bronchus here, so fistula can occur between alveoli or bronchus to the pleural cavity, and air coming via this pathway can go here and get trapped here. Similarly, while inspiration, air comes here, and during expiration, this opposes each other, and so little air leaks out. So air trapping occurs. And if air gets enough trapped, then what it causes? It causes tension effect. It starts displacing all these tracheobronchial tree, and air is hard, so it starts compressing heart, and it can cause cardiac arrest. So tension pneumothorax is medical emergency. So we insert tube in pneumothorax if the size is greater than 2 cm from the wall of pleural, from the chest wall. So let's suppose this is the chest X-ray, and here is the pneumothorax. Here is your pneumothorax. So if this diameter is greater than 2 cm from the wall, then it means that there is high or enough air to cause airway compromise, so we need to drain it out. But if it is less than 2 cm, then it can get self-resolved. So how it gets self-resolved? Here is air, so it is oxygen, nitrogen, 75% nitrogen, and oxygen is 20%, because in air, atmosphere is about 75% nitrogen and oxygen 20%, and nitrogen does not dissolve in blood, or this has less dissolving capacity than oxygen. So if you give oxygen via nasal cannula, what happens that this oxygen comes here and it starts occupying in this oxygen, and it displaces nitrogen to the blood. So it helps in dissolving nitrogen in the blood. So it is not that nitrogen does not dissolve in blood. I initially told that nitrogen does not dissolve in blood, but it has less dissolving capability than oxygen. So to promote nitrogen dissolution in the blood, we give oxygen. And you think that, oh, oxygen comes here, now oxygen gets trapped here, nitrogen dissolved, but oxygen is trapped here. So oxygen has, that more dissolving capability, so oxygen will later also dissolve. But the main problem that is creating is nitrogen, because nitrogen is not getting dissolved in blood. Whatever is oxygen component here, this has high dissolving capacity, so it dissolves, but nitrogen is getting trapped, so nitrogen is problem. So to displace nitrogen, we give oxygen, and this air can get dissolved in the blood and air escapes from here. So if the diameter is less than 2 cm, then just oxygen support will help in resolving pneumothorax. But if diameter is greater than 2 cm, then obviously there is some pathology. Either the pneumothorax has occurred through open trauma, or there is bronchopleural fistula, because from where this air is coming. So you might think that if there is air, then we can aspirate it. By 50 ml syringe we can aspirate all the air. Then why do you need to insert pigtail or tube inside the pleural cavity? So the reason is that if there is fistula, let's suppose, if you drain out the air, then it will again accumulate. If you drain out, it will again accumulate. So you have to do multiple punctures daily. Until this bronchopleural fistula resolves, you have to do aspirations. So better than that, put a pigtail. This pigtail will automatically drain whatever air comes via this pathway. Or we can also put chest tube that will automatically drain the air. So when you see any chest X-ray, and if you see that in this X-ray there is effusion, then what do? We send for analysis of the pleural fluid, whether it is transudate, exudate, if exudate, whether it is infective fluid or non-infective fluid. So if it is transudate, then we don't need to put tube inside it, because you know the lymphatics of the pleural cavity is so strong, it drains 20 times more than what it can accumulate here. That much resorptive capacity those lymphatics of pleural cavity have. That's why normally pleural fluid does not accumulate in our pleural cavity. Even with hydrostatic pressure, those are constantly going there. But pleural lymphatics are so strong that those pulls out all the pleural fluid. It has 20 times more absorptive capacity than the hydrostatic pressure of the blood vessels that creates the fluid in the pleural cavity. So if it is transudative effusion, you can give diuretics, sodium restriction, water restriction, and you will see that it will slowly resolves. It gets drained by lymphatics. But if it is causing significant compromise to the respiratory status, to the cardiac status, patient is desaturating, tachypneic, then we can do thoracocentesis. Insert needle 50 ml syringe and drain 1 liter, 2 liter fluid intermittently. So we can do that. But we don't need to insert plastic tube. But let's suppose it is exudate. So I think you know how do we differentiate exudate versus transudate. We look for protein concentration in the pleural fluid versus serum. In the pleural fluid versus serum, and we look for LDH. If this ratio are greater than 0.5 approximately, if protein concentration is more in the pleural fluid, LDH is more in the pleural fluid, then it suggests that it is exudate. And if you go by Light's criteria, it tells that even if you have any one of three, either pleural fluid protein ratio or LDH criteria, there are two LDH criteria. One is ratio of LDH and another is greater than 2/3 serum LDH. So if any one of these is positive, it tells that you have exudate. But if you go by this criteria, about 25% of the cases that we see, those falls under exudate, but actually the fluid is transudate, so it overestimates exudate. In that case, if you suspect a patient may be having transudative effusion, like fluid is translucent, patient does not have focus of infection, no fever, patient is not toxic looking, so in this case you can confirm with the protein gradient between serum and pleural fluid, or albumin gradient between serum and pleural fluid. If protein gradient is serum minus pleural fluid protein gradient is greater than 3, it means it is transudate. Or serum minus pleural fluid albumin gradient is greater than 1, it means it is transudate. So that is about distinguishing transudate and exudate. So let's suppose now your fluid is exudate. So you have to distinguish whether it is infectious fluid or not infectious. So sometimes there is consolidation here, and that is creating reactive infusion. So even in pneumonia we sometimes see transudative effusion. So if there is transudative, we don't need to insert tube. So I am not telling infection in the tracheobronchial tree, I am telling whether infection bacteria are in the pleural fluid or not. So even if there is pneumonia consolidation, this fluid can be transudative. Due to reactive effusion, this transudative effusion has formed. Or if bacteria are also coming here and bacteria also starts proliferating in the pleural fluid, then that creates exudate that can progress towards empyema, pus. So we have to distinguish whether it is infectious or not infectious. I am talking about pleural fluid, whether pleural fluid has bacteria or not. In TB, if you also see, sometimes there can occur reactive effusion due to tubercular protein. But sometimes what happens, that tubercular bacteria comes in the pleura here through hematogenous route and resides here. So sometimes we can get gene export positive, sometimes we get gene export negative. So even bacterial infection can cause infective pleural fluid or not infective pleural fluid. So that's why we need to separate whether it is infective versus not infective pleural fluid. What are the criteria that suggest you pleural fluid is infectious? Like you can see pH. If pH is less than 7.2, glucose is less than 40, LDH is greater than 1000. This suggests that there are bacteria that is consuming glucose, producing proteins and recruiting more cells, neutrophils, lymphocytes, and that is creating acidic environment. So it is likely that it is infective. You can confirm with gram stain culture. You can send the gram stain culture. If gram stain culture comes positive, then definitely there is bacteria. And if that bacteria or the focus is causing sepsis, we have to drain it. So we can drain with either tube, or if it is thick, then we have to insert tube, chest tube. And what are other non-infective cause of pleural effusion? Another is most common is malignant effusion, malignant pleural effusion. Sometimes what happens that this malignant cells either arise primarily here or comes from metastasis from other parts of the body like breast carcinoma, lymphoma, and resides here and elicits inflammation, and effusion occurs in the pleural fluid, pleural cavity. So that is malignant effusion. And other infectious cause, I already told, bacteria, tuberculosis, those are commonly that we see. And there are variety of causes, like if there is lymphatic disruption, then cholesterol can accumulate, triglycerides can accumulate. There are levels. Blood can accumulate in hemothorax, urine can accumulate, that is called urinothorax. So those are all exudatives, and those exudative needs to be drained out. And connective tissue disease related exudative effusion, generally we don't drain it. Even if you give immunosuppressants, steroids, this resolves. So connective tissue disease like RA related, rheumatoid arthritis, SSL related, generally we don't drain it, or for symptom relief we can do thoracocentesis, but we don't put plastic tubes. So now let's suppose you have kept chest tube and you did chest x-ray. It seems that the tube is in place in the pleural cavity, it is not kinked, it is draining effectively, and you shifted patient to ward. So what are the things that you should monitor daily in a patient who has chest tube? One is tidalling, another is air leak. So what is tidalling, air leak? Let's suppose this is the chest cavity, these are the lungs, and from here the chest tube is coming and there is connector, and with this connector you have connected to the bag, and we dip the tip of the tube inside the water, like 100 ml sterile water we keep it. We dip the tube so that air does not get sucked in while inspiration and air comes out while expiration. So when the patient inspires, this water moves up. because due to negative section this comes like up to here, and when it exhales the water comes down, and air, if there is pneumothorax, then air comes out. So this is called tidling. Water moving up and down is called tidling. So why do you need to see whether tidling is occurring or not? We have connected tube, so obviously tidling will occur if it is in pleural cavity. But why do you need to see daily whether tidling is occurring or not? Sometimes what happens, this tube gets kinked inside or gets displaced inside. So if there is obstruction, this tidling will not occur. Then you have to again manipulate. Or if there is thick fluid, or if there are multiple loculations, if one loculi is drained and there are fluid in other loculi, then fluid will not come here. Then you have to manipulate tube. So you have to look whether tidling is occurring or not to ascertain it is not kinked, it is not obstructed, it is not displaced. Another thing is you have to check for air leak. Air leak means air is coming through this pipe. Like if you see constant bubbling coming in the water, it means that air is coming. So from where the air is coming in this pipe? So what are the potential sites air can come here? So one is the tracheobronchial tree. If there is bronchopleural fistula, alveolopleural fistula, then air coming from this tract is coming here and air continuous bubbling is occurring. Another is air can leak through this pipe. There is a connector. So air can leak, get enter inside, air comes in this direction also, it goes in this direction also. Another is here, where you have inserted the tube on the chest wall and the muscles, musculoskeletal skin layer, where if there was big incision, or if it is not completely sealed with gauze pieces, not tightly dressed, then air can leak inside through this path, and it can also come through this path because there is the large incision or it is not correctly sealed. Then this, if this air goes inside, then this air also comes through this pathway. So if you see bubbling, air is either coming through this or through the incision site, or it is coming via this route. So how do you confirm whether from where this air is coming? So what you do, you clamp here. Then if still air is coming, it means air is entering from here and air is coming here. It means air is not coming from here because we have clamped it. So definitely air is coming from here and bubbling is occurring here. But if you have clamped and air is not leaking, it means the source was here, either through this pathway or whether through this pathway. So if the problem is here, you have to connect the connector tightly, put some tapes around it so that leakage does not occur. If the problem is here, if you see that dressing has not been done tightly, there are not enough gauze pieces there, then do tight dressing around the tube so that air leakage does not occur via skin, via muscles. And if the problem is here, then you have to wait and watch, because bronchopleural fistula takes time to heal on its own. When there is a wound anywhere, when there is disruption in the tissue barrier, then it takes few days to heal. So in the interim we can keep chest tube. So bronchopleural fistula can be iatrogenic, because initially, let's suppose there was no bronchopleural fistula, but if you inserted, you poked a little bit more the tube, plastic tube inside, it created bronchopleural fistula. Or patient may be having bronchopleural fistula from the beginning, because if there was any consolidation, a malignancy that has itself created bronchopleural fistula. So if there is bronchopleural fistula, wait for 5 days and see whether it heals automatically or not. And if it does not heal, then we have to do either blood patch, or we can put Helmich valve, endobronchial valve in the bronchus, so that air does not leak in the pleural cavity. There are some valves, if you can insert this bronchoscopically, the valve here, during inspiration the air won't go in the pleural cavity. or you can do blood patching as well. Through video assisted thoracoscopic surgery, you can put some blood here and it seals the bronchopleural fistula from where the air leakage is occurring. So I was telling about air leak. So you check for tidening, you check for air leak, and what other things you check? Drain output. So in the drain, how much fluid is coming? Like let's suppose it is coming less than 100 ml per day, but you do it X-ray, effusion is still there, but in drain you are not getting output. It means there is obstruction. You have to manipulate again, or you have to infuse tissue plasminogen activator. You can use 10 mg or DNase. Those dissolves the loculations, those makes the fluid thin so that drainage occurs. If less than 100 ml per day for 2 to 3 days, if you see 2 to 3 days, and if in X-ray if you see the effusion is resolving, then you can take out the tube. There is no need to put the tube for more days because the effusion has resolved, patient has clinically improving. So you can take out the tube. So this was about chest tube. Now let's talk about pleurodesis. So what is pleurodesis? So I initially told that parietal pleura and visceral pleura are almost opposed to each other normally. But when there is malignant pleural effusion, then this parietal pleura and visceral pleura gets far from each other. And you know, malignant cells are constantly eliciting inflammation. Due to that, there is constantly effusion is occurring. So even if you drain once, it will again accumulate. So in that case, what you have to do? You have to insert indwelling pleural catheter. And that indwelling pleural catheter, in the long term, what it does that, if you put the pleural catheter for long term, then it elicits mechanical inflammation because there is plastic tube there. So wherever in the body, if you put any plastic tube, inflammation occurs there because it considers that particle, that tube as foreign, and macrophages, monocytes, lymphocytes comes there and it starts eliciting inflammation. It starts reaction, and that due to fibrosis can occur here and it can approach each other. That is called pleurodesis induced by mechanically induced due to tube. Another is chemical pleurodesis. You can instill some chemicals like talc, silver nitrate, doxycycline, tetracyclines, povidone iodine. If you instill those, then that also elicits the same inflammation and opposes the parietal and visceral pleura with fibrosis. But where do you not to do pleurodesis? You also should know that. Where to not do? In trapped lung, we don't do pleurodesis. What is trapped lung? So as the name says, there is some trapping occurring. Lung has been trapped. So let's suppose this is the tracheobronchial tree and here is the parietal and visceral pleura. And this visceral pleura, let's suppose this has been scarred, fibrosed, so thickened that it is not compliant to expansion of these alveoli. These alveoli tries to fill with air, but this is not letting it expand, either due to malignant infiltration of the cells or chronic tuberculosis of the pleura or any other pathology, that this whole visceral pleura has become scarred. And this lung is trapped in this visceral pleura. This is called trapped lung. So when this visceral pleura gets scarred and parietal pleura is little far, then there is creation of this artificial cavity here. Because normally this visceral pleura moves due to its elasticity and this cavity is obliterated. But since this has adhered, there is creation of artificial cavity here. We call it ex vacuo. Vacuum has created here. And wherever there is vacuum, it either pulls air or either pulls fluid. So here there is no connections from where it can pull air, because it has been scarred, so scarred that there is no chance that it pulls air from alveoli. So there are blood vessels traversing in the pleura, so it pulls the fluid from the vessels and effusion occurs here. That is called pleural effusion ex vacuo. Pleural effusion ex vacuo. Effusion has occurred due to vacuum creation in the pleural cavity. You might have heard the term hydrocephalus ex vacuo, where there is brain atrophy and due to less brain volume, less parenchyma, CSF increases. Similarly, here vacuum has created, so to obliterate that vacuum, effusion has formed. So in this condition, if you drain with thoracocentesis or tube, it will again re-accumulate, because this is artificial cavity, this is completely scarred. So if you drain it, again reaccumulate, again drain it, again reaccumulate it. So here inserting tube is not beneficial. So what you have to do? The problem is here, this has been scarred, so you have to decorticate it. Do VATS and remove all this pleura surgically. Now you removed all this pleura, now this alveoli can expand. So decortication, peeling of the visceral pleura is the treatment of fibrosed visceral pleura, scarred visceral pleura. So even if you see in the CT, visceral pleura is fibrosed, thickened, then we can do decortication. We peel off the visceral pleura that with video assisted thoracoscopic surgery. We don't do generally open surgery in the chest if the problem can be solved with video assisted thoracoscopic surgery.